Okay, so now we'll begin the lecture on female reproductive problems. So problems related to menstruation, we'll discuss that first. So premenstrual syndrome. Premenstrual syndrome is defined as a cyclic phenomenon. It's individualized, yet basically the person, individuals with PMS have a consistent pattern of symptoms that occur between ovulation and menses, and those symptoms tend to regress or disappear during menstruation. So the etiology of PMS is unknown. It's possibly due to a estrogen and progesterone imbalance, and so due to the increase of estrogen that we see with ovulation, this may be one of the reasons that the person experiences some of the symptoms. Also, during menstruation, you have a change in serotonin levels, you have prostaglandin interactions. So all of us naturally have prostaglandins, and so what prostaglandins do, they cause spasms, and so the person, because of the increase in prostaglandin activity, the person may experience spasms of the uterus, and also stress. So a number of things can cause PMS. So to pinpoint one specific thing, we can't do that. Clinical manifestations are going to be non-specific, and they vary from person to person. Symptoms can occur 1 to 2 days or 2 weeks, and can vary in severity from month to month. And so usually the person may have nausea and vomiting, bloating, cramping, loss of appetite, and other people may have cravings during this time. Breast swelling, acne, fatigue, weight gain, back pain, anger, anxiety, irritability, depression, and violent behavior. So usually, as I said, the timing has to do with the timing with the start of the woman's cycle. And so you can ask the person to keep a menstrual record, and so this is to record the symptoms experienced, time the occurrence of the experiences, to make sure all of these things are related to the menstrual cycle. If they're not related to the menstrual cycle, maybe there's something else going on. Maybe there's a metabolic cause, or maybe a gastrointestinal cause. So we want to make sure if the person is coming in with vague, non-specific symptoms, that it is in fact due to PMS. So with medical management is going to be symptomatic, and usually we're treating the pain associated with it. And so NSAIDs are what we use to treat the pain and discomfort associated with PMS. And so NSAIDs, the reason we give those is because NSAIDs are prostaglandin inhibitors. So I mentioned before that prostaglandins cause uterine contractions. They also cause GI and vascular smooth muscle spasms. So again, this is why the woman is having that abdominal pain, maybe pain in the legs. So the NSAIDs are going to block the activity of the prostaglandins. So dysmenorrhea is again, when we talk about etiology, when we look at a primary cause for it, there's no pathology associated with dysmenorrhea. There's no problem with the reproductive organs to account for the pain. So it's not to say that the person has uterine disease or cervical disease. There's no pathology associated with the reproductive organs. Secondary dysmenorrhea may be associated with PID, and we've already talked about PID, pelvic inflammatory disease. And so dysmenorrhea can begin 1 to 2 days before menstruation and can last throughout menses. Okay, so dysmenorrhea is menstrual pain that occurs around the time that the menstrual period first starts. And menstrual pain, dysmenorrhea is described as a dull, throbbing, or cramping pain in the lower abdomen. So with that pain, lower abdominal pain, this pain can radiate to the lower back, the groin, or the thighs. Again, it's associated with uterine contractions or that high level of prostaglandins. So treatment, oral contraceptives may be used because they're going to inhibit ovulation. And the reason we want to inhibit ovulation, because this pain occurs with the ovulatory cycle. And so birth control pills or oral contraceptives inhibit ovulation, and birth control pills basically tricks the woman's body into thinking it's pregnant every month. As far as the pain, again, NSAIDs, ibuprofen, rest is going to help, hot fluids, heat to the abdomen, mild exercise may help. So pretty much those are the only things that we can do for dysmenorrhea or, painful menstrual cycles. So abnormal vaginal bleeding. In your book, it's also listed as dysfunctional uterine bleeding. And so these are some different types of irregular bleeding. Oligomenorrhea is when a person has infrequent or scant episodes of bleeding, whereas when you have secondary amenorrhea, this is an absence of menstruation for 6 months after irregular cycles have been established. So when a person develops secondary amenorrhea, well, then the doctor is probably going to check them for pregnancy first, and then outside of that, then they're going to do more diagnostic exams. With menorrhagia, this is excessive bleeding, and so the person is bleeding excessively in amount and in duration. And metrorrhagia is bleeding that occurs at irregular times. It's not excessive, but this is spotting or breakthrough bleeding. And so metrorrhagia can often be caused by pregnancy-related disorders, ectopic pregnancy, or threatened abortion. So anytime a person has bleeding that's unrelated to the menstrual cycle, they would want to follow up with the doctor, because we'll talk about different disorders of the endometrium, of the cervix. And so anytime a person has bleeding that's not associated with the cycle, they want to have that followed up to make sure that it's not cancer. It's not a cancerous lesion or cancer of that organ. So, conditions of the vulva, vagina, and cervix. So, first of all, the vulva is the external female genitalia. So, the vulva is the labia majora, minora, the mons pubis, the clitoris, the vestibule, and the vaginal orifice. All of that is what makes up the vulva. And so, to discuss some different conditions here, vaginitis is an inflammation to the vulva, the vagina, or the cervix. And so vaginitis can be caused by mechanical or chemical irritation. A person that wears really tight clothes is at risk for developing vaginitis. Exposure to fecal matter. This is why we teach our little girls early to wipe from front to back. External irritants like bath soaps, powders, feminine hygiene sprays, and definitely sexual intercourse can lead to vaginitis. So, other things that can predispose a person to the development of vaginitis is when we have an overall decrease in our body in our body defenses. So anything that's suppressing our immune system. Diabetes is one of those diseases that suppresses or weakens our immune system. And so antibiotics also, if we're taking really strong antibiotics, they can change the pH and decrease our normal flora. So our normal flora is our good bacteria that's supposed to fight off bad bacteria, but if we're on antibiotics, very strong antibiotics for an extended period of time, it can decrease our pH and decrease our good bacteria. Some of the signs that we see associated with vaginitis, The person may complain of burning, discharge. Those are the most common symptoms. The discharge, you want to make sure that you're noting the amount, the color, consistency, the odor, and this will help to determine the causative agent. We're doing an assessment about symptoms. We want to ask them about the duration of the symptoms, any comfort measures, what has helped with the symptoms they're experiencing. Again, we want to ask about the characteristics of discharge, sexual activity, if the person is practicing safe sex. We want to ask about the use of perfumes and powders. The doctor may perform a pelvic exam to determine the cause. What will be noted on the examination is that the vaginal mucosa will be very erythematous. We want to also, for this person, rule out STD or treat the STD. So definitely want to make sure that's being done. We've already talked about STDs, so if this person has an STD that has caused the vaginitis to occur, definitely we're going to treat them and treat the partner. And so again, treatment, we're going to remove the offending agent. If this is a person with diabetes, we've got to get those blood sugars under control. Sugar, as I said, sugar is a medium for bacterial growth, and so definitely we want to encourage the person to get their blood sugars under control. If the person likes to take bubble baths, well then we're going to remove the offending agent and discourage the use of powders and soaps that are going to cause vaginitis. If it's an infection, we can give anti-infectives, and sitz baths can be done to provide relief. With endometriosis, this is when tissue from the endometrium is the lining inside of the uterus. And so what happens with endometriosis, tissues from the endometrium of the uterus occurs or is relocated to other locations outside of the uterus. And so some common locations that this endometrial tissue may migrate to, it can migrate to the ovaries, the pelvic ligaments, the bladder, the ureters, the peritoneum. I think I've even read somewhere that it can even be displaced to the heart. And so theories for the cause for the displacement of endometrial tissue, one has said that endometrial tissue is propelled upward during menstruation. Another theory is that the endometrial cells from the uterus are carried by the blood or the lymph to secondary sites. So no matter the reason, what we have to remember about endometrium, or about the uterine endometrium, is that this is the part of this is what's shed during menstruation as a result of estrogen and progesterone. And so every time the woman begins the menstrual cycle, no matter where this tissue resides, whether it's in the bladder, ovaries, or in the uterine cavity, that area is going to shed, and the person will bleed from that site the way that they would from the uterine cavity. So the abnormally large endometrial tissue is going to undergo the same changes because of that, because of the influence of estrogen and progesterone. So this woman may have an increase in bleeding. Okay, so the drug therapy for endometriosis, birth control pills can be used to treat endometriosis. Again, it tricks the body into thinking it's pregnant. It's suppressing ovulation. And so it's suppressing ovulation and therefore inhibiting estrogen. And so if we're stopping ovulation, well then the endometrium has no reason to slough off or to shed every month. Surgery can be done to remove endometrial implants if the person has endometrial blockages, such as in the fallopian tubes. There are procedures that can be done to remove the blockages, especially in women that want to have babies. And so definitive surgery involves the uterus, the fallopian tubes, and the ovaries before for the woman that wants to become pregnant. So this is just an example of endometrial implants. So when we talk about benign tumors, first we'll talk about Leiomyomas, and so these are also what we refer to as uterine fibroids. And so uterine fibroids are smooth muscle tumors found in the walls of the uterus. It's the most common tumor of the female reproductive tract, and it's estimated that 1 in 5 women over the age of 35 have a uterine fibroid or multiple uterine fibroids. The development of fibroids seems to be linked to excessive estrogen. And so these tumors slowly develop during our reproductive years, and so they may accelerate during pregnancy, but after menopause, those fibroids may begin to atrophy. So the clinical manifestations that we see associated with it, in many cases they may have no symptoms, but a person that is symptomatic may have excessive prolonged menstruation. This is the most common symptom of uterine fibroids. This happens because the tumors form within the endometrium, and so because of that tumor forming within that endometrium tissue, it actually increases the endometrium surface, and so you have more area to shed every month, and so this is why the person experiences excessive or prolonged menstruation. Medical management is going to depend on the severity of symptoms, the age of the patient, the location, the size of the tumor, and the presence of complications. And so a hysterectomy may be the treatment of choice, but again, this depends on how many, if the person has multiple fibroids that are causing them a lot of discomfort, you have a person that's bleeding excessively outside of 21 days, and it's causing other problems such as anemia, fatigue, maybe some cardiac issues, well, this person may elect to have a hysterectomy performed. A myomectomy may be performed, and this is performed when childbearing is the aim, and it's done to relieve the symptoms. So at this point, only the fibroid is removed. So this is, the person that only has one fibroid, but for a number of women, they have multiple fibroids, and they can tend to be large in size. Okay. So benign ovarian tumors, polycystic ovary syndrome is a chronic disorder in which benign cysts form on the ovaries. It can be caused by increase in LH, that's luteinizing hormone, and as a result of this increase in LH, it stimulates growing follicles within the ovaries. When this occurs, the ovaries fail to release eggs, and so for polycystic disease, it's diagnosed with the ultrasound, and the ultrasound usually shows enlarged ovaries and cysts. So the clinical manifestations of a person that has POS are irregular cycles, oligomenorrhea, and infertility. Maybe the person complains of excessive acne. So remember that oligomenorrhea is when a person has infrequent or scant episodes of bleeding. So definitely the person is having irregular cycles. The treatment for POS, birth control pills will help to regulate the cycles. If this is a woman that is having problems with having a baby, then Clomid, CLOMID, can be used for infertility, but bilateral removal of the ovaries or fallopian tubes may have to be performed if the symptoms persist. And this is just an example of POS. I also wanted to speak briefly to cervical polyps. And so cervical polyps can be single or multiple, and they usually develop on an area on the cervical mucosa. Okay, cervical polyps are usually small, bright red, and they can protrude out of the cervical canal. The tip of the polyp usually has an ulceration on it, and this is because this is most likely due to friction that can occur during sexual intercourse, if you think about the anatomy and where the cervix is. So clinical manifestations: small polyps usually have no symptoms. The larger polyps, the person may have bleeding, and this bleeding can be similar to that associated with early cancer of the cervix. So definitely, if this is a situation, the person may need to have a biopsy performed. The bleeding may be intermittent, and the person may have contact bleeding that occurs after intercourse, douching, or a vaginal exam. And so this is usually diagnosed during a manual exam, during a pap exam, and they can also be palpated during a pap exam. Small polyps are usually visual during a speculum exam. And so polyps associated with symptoms may be easily removed if not attached to an internal structure. Okay. So we'll get into the cancer portion of this lecture. So cervical cancer, this is the second most common cancer in women worldwide. It's the 14th most common cause of women in the U.S. Effective screenings with pap smears and treatment of existing malignancies have reduced the death rate. So people that have been diagnosed with HPV, this person that's meticulous to stay on top of their pap smears and exams, things like that have decreased the death rate from cervical cancer. A failure to follow up, however, is the leading cause of cancer development and possibly death. The risk factors that we see associated with cancer, with cervical cancer, definitely HPV, which we've talked about before, infections of the external genitalia and the anus with HPV, a history of STIs, sexually transmitted infections, smoking, obesity, multiple pregnancies, long-term use of birth control pills, a family history, and HPV, as I mentioned again, is the most important risk factor. So when we look at diagnostic tests for a cervical exam, usually as it mentions, it develops in the cervix or the cervical epithelium. And so during a pap exam, the doctor may note that there are abnormal cervical cells. And so this treatment, after the pap exam, it can be followed up with a colposcopy. And we kind of talked about that. The physician goes in with a scope and they may take tissue samples. A cervical biopsy can be performed. And there's also another procedure. It is what you'll see on this YouTube link. It's a LEEP procedure. That's LEEP, and that stands for Loop Electrosurgical Excision Procedure. And so a LEEP allows diagnosing and treatment of lesions found on colposcopy. So as far as clinical manifestations, again, this is one of those cancers where the person may have no symptoms. If the cervical cancer is invasive, once it begins to grow and develop, there may be vaginal bleeding after intercourse or between menstrual periods. The person may have a brown bloody discharge that increases as the cancer progresses. And so as the cancer progresses, the person may complain of pain in the back or the thighs, hematuria, bloody stools, anemia, and weight loss. Cervical cancer spreads to neighboring accessory muscles, including the vaginal wall, the pelvic wall, bladder, and the rectum. And distant metastasis is also possible through the lymphatic system. And so how do we treat this? Well, prevention is important. And so a person that has developed genital warts, cryosurgery is good, is helpful to freeze off those warts. And if they've become cancerous warts, then cryosurgery can be done to freeze those areas off. If the cancer has become invasive and has spread to the neighboring accessory muscles, accessory structures of the pelvic wall, then a hysterectomy or radical hysterectomy, which is removal of the uterus, fallopian tubes, lymph nodes, and ovaries, that may have to be performed if the cancer has become invasive. Now the book talks about one book talks about a pelvic exoneration, and that is when a person has the removal of all pelvic contents. So that's the bowel, the vagina, the bladder, and the cancer. And so this is usually done if the cancer returns, and if it's very aggressive, the person has all those pelvic contents removed. And so you can imagine the care of that person that has bowel removed, bladder. This person will have to have a means of eliminating waste, so they have to have ileoconduits. This person will need a colostomy. So we're dealing with a person that's going to be dealing with a lot, probably some depression, definitely some body image disturbance as a result of this surgery. This is an example. This is a speculum exam, and this is a picture of a cancerous cervix. So with endometrium cancer, this is, remember that the endometrium is the inner lining of the uterus. And so endometrial cancer is the most frequently diagnosed pelvic cancer in the U.S. Most cases are diagnosed in older women, with more than half of the cases diagnosed in women between the ages of 55 to 74. The risk factors for endometrial cancer are prolonged estrogen stimulation and obesity, estrogen therapy, prior radiation to the pelvic region, so a person that's been treated for something else and received radiation, women who began cycles at an early age, diabetes, polycystic ovaries can alter estrogen metabolism and can lead to the development of endometrial cancer. The risk is decreased, however, for the person that uses birth control pills or an IUD, an intrauterine device, without hormones to prevent pregnancies. So, we kind of mentioned in class, sometimes the use of birth control, it's kind of a catch-22, because sometimes birth controls increase your risk of certain types of cancers, whereas other times it decreases your risk. So I guess it just depends on the woman and how distressing the symptoms are when we talk about things such as fibroids and dysmenorrhea, if they want birth control to help with those symptoms. So usually there is no screening for endometrial cancer or uterine cancer. That's the scary part about it, because every time women have Pap exams where then they're looking at the cervix, they may do a bimanual exam that palpates the ovaries. Well, we don't necessarily have the uterine assessed during a Pap exam. So signs that prompt a woman to go in and be treated or evaluated, abnormal painless vaginal bleeding may be the only sign the woman notices. So menorrhagia or metrorrhagia may occur, and so later manifestations include pelvic cramping, bleeding after intercourse, lower abdominal pressure. So sounds like the same types of things that we see with cervical cancer. So definitely a biopsy has to be done to see what type of cells we have. If they're still differentiated, we can tell where those cells originated. So again, To diagnose this, a transvaginal ultrasound will have to be performed, and it's used to determine endometrial thickening, which may indicate hypertrophy or malignant changes if the endometrium has become thickened or larger. Endometrial biopsy, definitely need that, or a D&C can be done. A D&C is a dilation and curtilage. So this is where the cervix is dilated, and the doctor will take scrapings off the uterine walls, and so this tissue can also be used for diagnostic purposes. The surgery for endometrial cancer, the person may have a total hysterectomy with bilateral salpingo-oophorectomy, so that's the uterus, fallopian tubes, ovaries. It's all taken, and this is performed for stage 1 cancer. So a radical hysterectomy with no dissection is done for diseases that are stage 2 or beyond. Radiation may be performed. External and internal radiation may be performed as a preoperative measure or as adjunctive treatment in advanced cases. So remember, if we do it before, that's a neo-adjunctive, and so that's to shrink the tumor prior to surgery. Adjunctive means that we're doing that in addition to something else. So this person may have radiation in addition to surgery and chemotherapy. Hormone therapy may be used, and hormone may be hormones that are going to inhibit estrogen. With ovarian cancer, this is more common in older women. 10% of the cases have 2 or more first or second degree relatives who have had the disease, and so we often see persons with genetic mutations of BRCA1 and BRCA2 being at a greater risk of developing ovarian cancer. Other risks are increasing age, having no children, early menarche, late menopause. So again, remember, this person has been exposed to estrogen for an extended period of time. Infertility drugs, obesity, high-fat diets, a personal history of breast cancer. Hormone replacement therapy after menopause also places a woman at risk for developing ovarian cancer, because the hormone that we're replacing is estrogen. And so ovarian cancer usually spreads by local shedding of cancer cells into the peritoneal cavity. Or they may be spread directly through direct invasion of the bowel and bladder. So cancer cells in the peritoneum can implant in the intestines and the bladder. Early signs of ovarian cancer, again, a person may have no signs or symptoms. Later, the person may complain of feeling full quickly, abdominal bloating, urinary urgency, pelvic and abdominal pain. The person may have fatigue, back pain, pain after intercourse. And so these signs kind of sound like dysmenorrhea. Can sound, like it's associated with the menstrual cycle. So this is kind of another reason why doing that menstrual diary, like keeping up when the person experiences the symptoms, this is why this is going to be effective, because this person here, they feel this most of the time. Once the feeling, the full quickly and the bloating is not just associated with the beginning of the cycle. So this can be diagnosed transvaginal ultrasound again. CT scan of the abdomen or pelvis may be performed. MRI of the abdomen, colonoscopy, ovarian biopsy. A colonoscopy is done because we said that ovarian cancer is usually spread to the bowel and bladder, so we want to determine if the person has had any bowel or bladder involvement. So colonoscopy colonoscopy can be performed. A CA-125, this is a tumor marker that is highly specific and elevated in ovarian cancer. I think I mentioned during our cancer lecture, doctors won't routinely screen for CA-125 because there are other disorders, disorders, that can cause the elevation in CA-125. So this is usually more diagnostic to determine if cancer treatment has been effective. The treatment of ovarian cancer, well, for the woman who has stage 1 ovarian cancer, who may wish to have children, if the cancer has not spread to both ovaries, one ovary can possibly be removed. However, total hysterectomy with bilateral salpingo-oophorectomy, again, that's removal of the fallopian tubes and the ovaries, is performed. Total hysterectomy. Depending on the stage in the woman's general state of health, surgery may be combined with chemotherapy and radiation. With radiation, is using an external beam, or the person may have intracavity implants, so they're implanting it directly into the uterine cavity, and this is performed for palliative purposes. So we know palliative means that there's no cure, but it's done to shrink that tumor at selected sites. Vaginal cancer is when a person develops malignant cells that form in the vagina, and vaginal cancer is one of those uncommon types of cancers. The risk factors for vaginal cancer, development of vaginal cancer: increased age, having HPV, having a history of abnormal cells on the cervix, a history of abnormal uterine cells or cancer of the cervix, or cancer of the uterus, having a hysterectomy for health problems that affect the uterus. Vaginal cancer often does not cause early symptoms and may be found during a routine pelvic exam and Pap test. So when symptoms occur, they may be caused by vaginal cancer or by other conditions. So if the person is complaining of bleeding or discharge not related to menstrual cycles, pain during intercourse, pain in the pelvic area, a lump in the vagina, pain when urinating, or constipation, this should prompt follow-up treatment. And so due to the proximity of the vagina to the bladder and rectum, this limits surgical treatment options for vaginal cancer. For patients, for the patient with carcinoma of the vagina in early stages, radiation and surgery, or a combination of these two, may be the standard treatment. For patients with stage 3 or 4 disease, radiation is standard and includes external beam radiation alone or with brachytherapy. Regional lymph nodes are included in the radiation portal. Now, vulvar cancer, this most often affects the inner edges of the labia majora or the labia minora. This cancer occurs on the clitoris or in the Bartholin's glands, but these occur less often. So most often we see them affecting the labia majora or labia minora. Risk factors are kind of similar to what we've seen for the other diseases: increase in age, smoking, HPV, vulvar intraepithelial neoplasia. And so this is a squamous cell carcinoma of the vulva. It usually forms slowly over many years. It's often precancerous changes, and so these precancerous changes occur first and may last for several years. And so precancerous changes, when we talked in class about the initiation, these cells are kind of cells that have already been initiated, but then we add those other things in, like the smoking and the high dietary fat. This is when those precancerous cells can become promoted and become cancerous lesions. lichen sclerosis, that's Sclerosus. This is a disorder that causes the vulvar skin to become very thin and itchy. And so the risk of vulvar cancer appears to be slightly increased when a person has lichen sclerosis. Okay, so about 4% of women that have lichen sclerosis will later develop vulvar cancer. So as far as the symptoms, many women who have vulvar cancer may have itching, burning, bleeding on the vulva that does not go away, changes in the color of skin of the vulva, so it looks redder or whiter than is normal for you or normal for the person. Skin changes in the vulva includes what looks like a rash or warts, sores, lumps, or ulcers on the vulva that don't go away. Pain in the pelvis, especially when the person urinates or has sex. So diagnosis is the person has to have a biopsy, a cystoscopy, and also a proctoscopy, which is scoping the bladder and the rectum. These are performed again because vulvar cancer can spread to these areas. So when the cancer is more advanced, an extensive procedure may be necessary, and so this may be removal of the external vulval tissue. So remember everything that we said was included in the vulva. This is all of your external genital, such as your the clitoris, the labia majora, labia minora. So if the disease is advanced, the person may have to have a vulvectomy. There are different types of vulvectomies that can be performed. If the person has surgery, radiation can be combined with chemotherapy and surgery to kill more cancer cells. A skinning vulvectomy means that only the top layer of skin affected by the cancer is removed, so that's skinning, SKINNING. So although this is an option for treating extensive vulvar cancer, this operation is rarely done. Okay, in a simple vulvectomy, this is when the entire vulva is removed, and there is also a radical vulvectomy that can be complete or partial. And so when part of the vulva, including the deep tissue, is removed, the operation is called a partial radical vulvectomy. And in a complete radical vulvectomy, the entire vulva and deep tissues, including the clitoris, are removed. Okay. So, as we mentioned, for most of the cancers, we talked about ovarian cancer, uterine cancer, and cervical cancer, vulva cancer, and vaginal cancer. Radiation was used as an adjunctive therapy for most of them. So if you don't remember your time, distance, and shielding, make sure you go back and review that. Remember the difference between sealed and unsealed radiation. You'll go back and review those things. Also, we've talked about the different surgeries related to these organs. So with most of them, a hysterectomy was possibly needed. The pelvic exoneration, I talked about that in relation to cervical cancer. The vulvectomy was done for vulvar cancer. The hysterectomy, the salpingectomy, and oophorectomy, we saw those being associated with most of them, the endometrium, the ovarian, or the cervical cancer. So, as I mentioned, a person that has a total exoneration, that's when all of the pelvic organs are going to be removed, and so because of that, this person will have to have a ileoconduit for removal of urine, and a colostomy for the removal of waste products. So when we talk about pelvic problems with pelvic support, the first thing we'll discuss is uterine prolapse. And so sometimes because of childbirth, difficult labor and deliveries, some women may experience muscle weakness in this area. Also, as a woman begins to age, the natural loss of hormone, of the estrogen hormone, the uterus can drop into the vaginal canal, causing a condition known as uterine prolapse. So with first degree uterine prolapse, this is when the cervix droops into the vagina. With second degree uterine prolapse, this is when the cervix drops to the level just inside of the opening of the vagina. And then with third degree, this is when the cervix is outside of the vagina. Fourth degree, the entire uterus is outside of the vagina, and this is caused by weakness in all of the supporting muscles of the pelvic cavity. And so again, I said some reasons that can cause this to occur: pregnancies, multiple childbirths, weakness in the pelvic muscles that occur during aging, weakness, loss of menopause, conditions that cause increased pressure on the abdomen, a person with a chronic cough such as bronchitis or asthma, a person that has chronic constipation, so this person is straining on a regular basis, a person that has accumulation of fluid in the abdomen. This may be associated with a person that has liver disorders and they start to develop ascites or build up of fluid in the abdominal area. Being overweight puts a strain on pelvic muscles. Excessive weightlifting is also a risk factor. So some symptoms that a person may complain of when the uterus has prolapsed: a feeling of fullness or pressure in the pelvis. And so the person may describe it and say it feels like they're sitting on a small ball. The person may have low back pain, feeling like something is coming out of the vagina, painful sexual intercourse, difficulty with urinating or moving bowels, and the person may also have difficulty walking. Okay, cystocele and rectocele. A cystocele is a herniation or bulging of the front vaginal wall where a part of the bladder bulges into the vagina. This may lead to urinary frequency, urgency, retention, and incontinence. Whereas a rectocele is a herniation of the lower rear vaginal wall where the rectum bulges into the vagina. This makes bowel movements difficult to the point that the person may need to push on the inside of the vagina to empty the bowel. This is an example of a cystocele right here. And this is an example of a rectocele. So how do we treat these conditions? Well, for uterine prolapse, and I guess for all of them, we can encourage a person to do Kegel exercises, and we know that Kegel exercises are what exercises that are done to strengthen the pelvic muscles. For the person with uterine prolapse, estrogen therapy may strengthen the tissues of the vagina and increase support. Depending on the age, a woman may elect to have a hysterectomy. If it's uterine prolapse, she may just say, give me a hysterectomy and take the uterus out. A pessary may be inserted to provide support for those persons who are poor surgical candidates. And so a pessary is inserted into the vaginal canal. A woman must be fitted specifically. There's a risk of irritation and foul odor. And so if a woman has a pessary, it's inserted into the vagina. It needs to be cleaned and checked by the healthcare provider for correct position, and checked checked at regular intervals to make sure it's fitting correctly. And so a person also needs to receive instructions on how to care for the pessary once they're home. The rectocele and the cystocele can be some of the same type of approaches utilized. A colporrhaphy, which is colporrhaphy, can be performed. This is a surgical procedure in which the vagina is sutured to narrow it. And so this tightening is going to help tighten those pelvic muscles and increase support. And this should help with the cystocele or the rectal seal. And so again, encouraging those Kegel exercises, discouraging things such as straining, may help with the cystocele or the rectal seal.